Rahman Rahim. Today we'll speak about the placenta and the umbilical cord. Our objectives are to know the anatomy of the placenta at term, the function of the placenta, the hormone secreted by the placenta, what's abnormalities of the placenta, the anatomy of the cord, and the abnormalities of the cord. The placenta is the unit of connection between the fetus and mother. It develops from the decidua bizalis, it is the maternal part, and from the chorion frondosum as a fetal part. This is what is the normal anatomy of the placenta term. Its diameter is 20 centimeter. It is thick at the center, about 2.5 centimeter, and half this thickness at the periphery, and it weighs half kilogram, and it has two surfaces. The fetal surface, which is smooth and covered by the amnion, while the maternal surface is irregular and it is divided into 15 to 20 cotyledons separated by fibrous avascular tissue, which is the placental septa. This is the fetal surface, and this is the maternal surface with the 15 to 20 cotyledons. The function of the placenta is respiratory, with the exchange of gases between the mother and fetus. Nutrition, it transports everything: glucose, lipid, protein, vitamin, minerals. And it is secretory function. It secretes hormones, which is human choriogonadotrophin, human placental lactin, estrogen, progesterone, and relaxin. And the enzyme secreted is alkaline phosphatase, histaminase, oxytocinase, insulinase, and placental protein, pregnancy-associated plasma protein A, B, and C. Excretory function, it acts as the kidney for the fetus. Hemobiotic function, it produces fetal hemoglobin. And mechanical function, it fixes the fetus into the mother. The placental barrier is the tissue separating the maternal and fetal blood through which substance can pass from and to the mother, and its thickness is thick early in pregnancy, 0.1 millimeter, but after that become thin, 0.01 millimeter in late pregnancy to allow more perfusion in late pregnancy. And the layer before 20 weeks is formed of syncytial trophoblast, and cytotrophoblast, which is the Langerhans layer, and the mesoderm of the fetus, and the wall of the blood vessel of the fetus. And after 20 weeks, the Langerhans layer disappear and decrease the thickness of the mesoderm, so it becomes thinner. The function of the placental barrier is to prevent the mixing of maternal and fetal blood, so it prevents the passage of some organisms and drugs from the mother to the fetus. And it helps in gas exchange and transfer of nutrition and transfer of the waste product from the fetus to the mother. The mechanism of transport through the placenta is either simple diffusion as water transfer, facilitated diffusion by carrier in glucose transfer, active transport in amino acid transfer, and endocytosis to transfer large molecule like IgG. The placental hormone are human choriogonadotrophin, human placental lactin, estrogen, progesterone, and relaxin. The human choriogonadotropin it is secreted by syncytial trophoblast, and the normal level start to appear 1 day after implantation, and it reach maximum level at 10 weeks gestation, which is 100,000 milli-international per milli. Then it decreased till it reached its nadir at 20,000 milli-international per milli at about 15 to 18 weeks gestation till delivery. It is at this lower level and disappear from the blood and urine after delivery by 1 or 2 weeks. The action, it maintains the corpus luteum in early pregnancy till 12 weeks and stimulates this corpus luteum to secrete progesterone and play a role in immunological maternal acceptance for fetal tissue. And its clinical uses, it is used in diagnosis of early pregnancy, and it is diagnosis of ectopic pregnancy if we have PTHCG more than 1,500 milli-international per milli, and we introduce transvaginal sonography and there is empty uterus, so it is ectopic pregnancy. Allow a diagnosis and follow-up of gestational trophoblastic disease where there is a very, very high level of this human chorionic gonadotrophin. Also tumor marker in HCG secreting tumors. And we can use the HCG in induction of ovulation in infertile women. Here is how HCG is increased gradually till it reaches its peak. It reaches its peak at about 10 weeks gestation, and then it declines till it reaches the low level, which is 20,000 milli-international per milli till the end of delivery. And it is highly related to nausea and vomiting in early pregnancy. Human placental lactin, again, all the hormones of the placenta are secreted from the syncytial trophoblast. The normal level, it starts to appear since early pregnancy and increase steadily till before labor. And the action of this human placental lactin is somatotropic, increase the growth, lactogenic, it leads to milk formation, and erythrobiotic, increase the red blood cells formation. Estrogen, it is mainly during pregnancy secreted by the fetoplacental unit, which is 90%, and that's why it is estriol. Estriol during pregnancy, the main one is estriol, and the urinary estriol, the end product is urinary estriol, and is at a level of 30 to 35 milli per deciliter. And the action of an estrogen, it helps hypertrophy of the uterine muscle and increase the uterine blood flow during pregnancy, and it stimulates the prolactin synthesis, but it inhibits action because it inhibits its receptor to make lactation possible only after labor. And the estrogen increase at the last weeks of pregnancy, and this leads to the initiation of labor through stimulate the oxytocin receptor and increase the sensitivity of uterine muscle to this oxytocin. Also, it stimulates the prostaglandin release in late pregnancy and stimulate uterine contraction and also labor. Progesterone It is secreted from the corpus luteum, then after that from the placenta. And its normal level is more than 15 nanogram per milli at start, and then it progressively increased till 150 nanogram per milli at term. Then it decreased in the last week of pregnancy, maybe due to placental aging, and this is the main theory for starting labor pain. The action of the progesterone is to prepare for implantation and maintain the decidua, inhibit uterine activity throughout pregnancy. That's why when it decreases in the last week of pregnancy, it initiates labor pain. And clinical use, it is given in threatened abortion and in preterm labor. Relaxin is from the corpus luteum, decidual placenta, and its action is to do relaxation for the pelvic joints and ligaments. When we look at this picture and see how hormones are during pregnancy, we find that early in pregnancy, the main hormone is the HCG, which is secreted by the syncytial trophoblast, and this one reaches peak at 10 week. After that, it decreases at reaching the nadir at about 15 week to 18 week, and it is highly related to the early pregnancy nausea and vomiting. And it helps in maintaining the corpus luteum and help secreting the progesterone from the corpus luteum. After that, the progesterone is secreted from the placenta and it increases, and this is the main hormone all through after that. It is the main hormone to relax the uterus all over this pregnancy. But a week before delivery, it decreased so much so that labor pain can be initiated. And the estradiol is a low level, but it increases at the end of pregnancy, and it initiates labor also because it helps the action of oxytocin and the prostaglandin over the uterine muscle. It helps uterine contraction. Very important questions. What are the abnormalities of the placenta? There is abnormality in size and weight. There is abnormality in shape. There's abnormality in site of implantation, abnormal adhesion, abnormal insertion of the cord. Abnormalities of the placenta, abnormal size and shape, may increase the size and weight in cases of multifetal pregnancy, in case of diabetes mellitus and RHI immunization. Decrease in size and weight in hypertension and intrauterine growth restriction. Abnormal shaped placenta, we have placenta membranecia, which is diffuse placenta. And this is thin, large placenta, and it occurs as a result of decreased blood flow, so it increases its size to get more blood supply. We have a bilobate or multilobate, where there are two or more lobes connected by placental tissue. They may be bipartite or multipartite placenta, more or two lobes, equal, but they are separated by membrane. And saxenturate placenta, two separate unequal parts. We have small accessory part, and they are separated by membrane also. Circumvallate placenta, which is with a whitish ring at the fetal surface. Circumvallate may be due to calcification. and the placental fenestrata with the gap in the placenta like a window covered by membrane. Placenta annularis, where the central part of the placenta is absent. Here is the placenta membranaceae, large and thin placenta to overcome low blood supply. Fenestrated placenta with a gapped area covered by membrane. Bipartite placenta, two or more loops connected by membrane, but bilobate, two loops connected by fetal placental tissue. And here is accentuate placenta, where is the accessory loop connected to the placenta by membrane. And circumvallate placenta with which area around the fetal surface. It may be due to calcification. Abnormal site of implantation, either placenta previa, where the placenta is implanted in the lower transsegment, and ectopic pregnancy, where the placenta is implanted outside the endometrium. Abnormal adhesion, placenta accreta, where chorionic villi are attached to the superficial myometrium, and placenta increta, the chorionic villi invade deeply into the myometrium, and placenta percreta, where the chorionic villi invade the whole myometrium up to the peritoneum. This is some diseases of the placenta: infection, infarction, calcification, degeneration, retroplacental hematoma in abruptio placentae and accidental hemorrhage, placental cyst, placental neoplasia, twin-twin transfusion. The umbilical cord is a vascular connection between the fetus and the placenta. It's formed from connecting stalk and mesoderm. Its length at term is 50 centimeter, and it is about 1 to 2 centimeter in diameter. It is attached at the fetus, at the umbilicus, and it is attached in the placenta, and its attachment is in 70% eccentric and in 30% it is centric. Look, it is two arteries, two placental arteries, and one vein, like face, like face. Two arteries, but inverted. Two arteries, 2A, and one vein. One vein. The structure of the cord, it's formed of amniotic membrane, coat, give it the glistening appearance, Wharton jelly, extra embryonic mesodermal tissue, blood vessel, again two arteries, and the arteries carry the non-oxygenated blood from the fetus to the placenta, while the vein, one umbilical vein, which carry oxygenated blood from the placenta to the fetus. Obliterated coelom, and if they persist, it may lead to umbilical hernia, a remnant of yolk sac, a remnant of allantoins, and the function, it carries the blood to and from the placenta. And this is a common question: abnormality of the cord, abnormality in the lens or insertion of placenta, abnormalities in blood vessel, and notes. Abnormality in lens, the long cord more than 7 centimeters, and this may lead to cord prolapse, true notes, coiling of this cord around the fetal neck, leading to fetal distress and death, or it may be short cord less than 30 centimeters, and this may lead to malpresentation, malposition, delayed descent of the fetus, rupture of the cord, premature separation of the placenta with accidental hemorrhage, abnormal insertion of the placenta, a patellar or marginal insertion of the cord, and it is inserted into or near the placental margin. Filamentous insertion of the cord is inserted into membrane and the vessel connected to the placenta. And it may lead to vasa previa if this membrane passes above the internal os and the membrane rupture. There will be severe bleeding coming from the fetus with severe fetal distress and the baby may die. This is the eccentric insertion of the cord near the center. It is in 70%, and this is central insertion of the cord in 30% of cases. This is abnormality, the marginal insertion of the cord, the patellar insertion, and here is the filamentous insertion of the cord. The cord and the blood vessel connect to the placenta through a membrane, and if this membrane is above the internal os and the membrane rupture, the blood vessel come from the fetus, and there will be severe fetal distress. And maybe fetal death if not managed rapidly by cesarean section. That's why if we are doing amniotomy, rupture of the membrane, and there is severe bleeding, we have to check directly the fetal heart rate. If there is bradycardia, it is vasa previa and they have to do cesarean section at once. Abnormalities of blood vessel, we may have single umbilical artery, which is the most common vascular anomaly, or we have two umbilical veins. As regards nodes, we have true and false nodes. True, due to the passage of the fetus through loop of long cord, and false may be due to localization or localized accumulation of Wharton jelly or dilatation of the umbilical vein. This is a true node, and this is a true node by color Doppler, and this is false node, just maybe diverticulum or dilatation of the umbilical vein, and this is a single umbilical artery by Doppler ultrasound. Other abnormalities like hematoma due to injury of the umbilical vessel, maybe is a tumor, torsion, exophilus, congenital umbilical hernia, means there is a hernia at the umbilical cord, thickened and edematous in cases of erythroplastosis fetalis. This is an ultrasound that shows that there is a hernia at the umbilical cord, exophilus. This is some question, you have to think about it. Thank you.